Hi, I'm Dave Seaver of MindAlive. Today we're going to learn about transcranial DC stimulation. First, we're going to mention transcranial electrostimulation in general. Transcranial electrostimulation is an umbrella term that applies for several different techniques which stimulate the brain. Cranial electrostimulation, which has been around since the 1940s, and it's usually applied to the earlobes or mastoid. It's meant to target the brainstem and release neurotransmitters, particularly serotonin and endorphins. Most stimulation is done in the delta and 100 hertz range. However, the Delight Pro and the Oasis Pro can stimulate from 0.5 hertz to 50 hertz, while another device stimulates at about 15.5 kilohertz. Transcranial DC stimulation, which we're learning about today, is a direct energy, typically of 2 milliamps or less, and it is applied anywhere on the brain to excite or inhibit neuronal activity underneath the electrodes. Transcranial AC stimulation is an alternating current, so not direct current, but an alternating current. This means then that there is a frequency involved. DC has no frequency, but AC does. So it's an alternating frequency or current from subdelta to gamma in frequency. It is applied across two areas of the brain to increase brain waves of a deficient frequency band, typically as indicated on a QEEG. Then there's transcranial random noise stimulation, and TRNS is a proof of concept where the frequency mimics the actual firing rate of the neurons being stimulated. Most neurons are firing in the range of roughly 100 to 500 hertz, depending on what the neuron is doing. Now, tDCS has been tampered with or tinkered with for quite some time. We can see here, Duchenne and Ballon in 1855 were documented using tDCS to stimulate different psychiatric disorders. In this case, seeing where the electrode is placed, assuming that might be an anode, that could be perhaps treating depression. Baron Rockwell also documented back in the 1870s as well, using tDCS to stimulate or to treat different psychiatric conditions. Other people have been documented here and there. Giovanni Aldini, who was treating melancholy. 1874, Bartholow was doing motor strip experiments. 1964, Bindman and his group were doing DC stimulation on rat brain. Now, I would say Bindman is really getting into true scientific application of tDCS in 1964. Still, not much was done with tDCS until 2000, when Nish and Paulus, out of the University of Göttingen, out of Germany, started exciting the motor cortex, particularly with stroke patients and such, and have since spawned the entire current trending in tDCS research. So they were the initial starters of what has now translated into over 1,500 studies to date. So hats off to Nish and Paulus for being the ones to start modern trends in research on tDCS. Every single part of the brain that can be stimulated has been stimulated. And just hundreds of different clinical applications have emerged with tDCS research over the last couple decades. Well, probably more around 2014 when I collected these stats. It's difficult to keep up, but you can see studies on behavior, on depression and bipolar, motor and motor learning, tactile sensitivity, psychiatric, anorexia, OCD, language, aphasia and speech, memory, migraine, pain, Parkinson's, cognition, neurotransmitters, physiology, animal studies, lit reviews. And remember, I made this list in 2014. And so a great deal of research has been done since then. Cognition studies, you can see just how many there are here, different types of cognition studies. Behavioral studies, emotional studies. It's interesting on the behavioral studies how they also studies have done where they can basically influence deceit in lying, depending on the part of the brain that they stimulate and whether they're using an anode or a cathode. Psychiatric disorders, cognitive disorders. You see, there's all kinds of things here. Oops, pain studies. Quite a few pain studies, a lot of language studies. There have been a surprising number of studies actually done on stroke, probably in around 400 studies to this point, involving various forms of aphasia and ataxia and so on, motor strip issues, sensory studies of all kinds, addiction studies, physiology studies, and where they're looking at evoked potentials, theoretical models. tDCS has certainly spawned insights as to how the brain actually functions. And so all kinds of theoretical models about brain functioning have emerged with the development of tDCS. Brain function studies, cerebral blood flow studies, blood pressure studies, and so on. Neurotransmitter studies of various types have been spawned as well. Other studies, dreams, seizures, MRI, cerebellum studies, and there have been some fascinating stuff done with cerebellum and locomotion and so on. Spinal cord studies, animal studies, lit reviews. It's gone on and on. Ethics studies and efficacy studies, comfort, safety, and so on. Best methods of practices. So a lot of work has been gone on in tDCS since its original days, really starting with Leash and Paulus's research back in 2000. So anyway, what is tDCS? tDCS is a very simple technique. You couldn't ask for a more powerful psychiatric or neurologic treatment technique that is also fairly well priced and very easy to use. Anyway, a small electrical stimulus is applied to specific sites across the brain, and this stimulus actually is applied in terms of a current, not just an electric field or something like that. The electrical stimulus flows across the brain. tDCS affects pyramidal neurons and likely astrocytes, which are part of glia, and they serve to modulate neuronal activity, particularly in the beta-gamma bands. The anode enhances cortical function from 20 to 40% roughly, and the cathode inhibits cortical function roughly from 10 to 30%. And it can affect functioning typically in 15 to 20 minutes. It is very fast and very effective. When working with tDCS, it certainly does help to have a good understanding of all the Brodmann areas in the brain, and also all the electrode sites for using, when you're doing EEG work, using the 1020 or the 1010 electrode placement montage or scheme. It's good to know where the electrodes are sitting over which Brodmann areas to help, and not just making a diagnosis, but also in the treatment program. Here's an example here, and this is a bit of a poor example, but it was just kind of showing how we would do the band for placement. You can see the left one. If this electrode was a little more properly placed, probably in this area here, that would be for depression. And the headband is typically on like so. If we're doing more motor strip or even down the cingulate, precuneus area, then we would run the headband under the chin. And it works quite well. Things to know. tDCS is DC, meaning direct current, like that coming off a battery. So there is no frequency, and therefore there's an anode and a cathode. Generally speaking, if you have a frequency and it's biphasic, which a frequency-based stimulation generally is, then there is no anode or cathode because there is no actual polarity because they're alternating polarity all the time. But tDCS indeed has a polarity just like a battery has. So there's an anode and a cathode. The anode is positive and the cathode is negative. For me, this is what I used to do when I first got into this. I sometimes forgot which was positive and which was negative. And so anions, a twisted form of the word onions into anions, I like anions. So I have a positive experience with anions. I have allergies to cats, so I have a negative experience with cats. And that was sort of the little mnemonic I used in my early days to help make sure I kept positive and negative straight with anode and cathode. Now, another aspect of tDCS that's really, really important has to do with electrode size versus overall stimulation current. And this is called current density. And we're going to learn a little more about current density in the next few minutes here. Of the 15 or so 100 studies that have been done to date, 98% of them have neglected to address current density. So you'll read one study, they'll say, we did 2 milliamps into 49 square centimeters and we had no clinical effect. Another study will say, well, we did 2 milliamps into a 25 square centimeter electrode and we had great effects. And it's because you have to take the overall current and divide it by the size of the electrode or the area of the electrode, because the electrode in itself dilutes that current. So the larger the electrode is, the more diluted the current is, and the less clinical effect it will have. Niche and Paulus kind of discovered this later on. Another little problem that was going on, and is still being replicated in poor studies even today, is that often they use the same size electrode for the stimulus and for the reference electrode, and they'll often put the reference electrode on the head still. Often they use the contralateral orbit, but they can use other places as well. And rarely does a study ever address the negative effects that occur underneath that reference electrode. And it's a major failing of a lot of the research. And I think you have to be careful with that reference electrode. But Niche and Paulus, again, determined that, yes, it's much better to have a large reference electrode if it's being placed on the head. I prefer to keep my reference electrode off the head entirely, and I run it what they call extracephalic placement, which is usually on the shoulder. I generally run my reference on the contralateral shoulder to where the stimulus is being placed. Now, if I run the stimulus down the midline, as with cingulate or precuneus, or even FP1, FP2, if I'm running FP1, FP2, typically then I will use a neck reference. And if I'm running down the cingulate or precuneus, I will put the reference under the chin. And so those are the way I do it, so I make sure I don't cause any side effects from the reference in itself. Anyway, Niche and Paulus found that generally speaking, you needed to have at least 17 microamps per square centimeter to have sensory motor effects with transcranial DC stim. I have found, and other studies have found, that for the most part, depression, anxiety, cognition, aphasias, and so many of these other studies we just looked at require typically at least 40 microamps per square centimeter or more. I often work with 100 with a lot of my clients. And part of the reason with that too is, you want to get the best bang for your buck, but you also want to make sure that your client feels the effect right on the first treatment session. If they don't, you might lose them as a client, but if they're buy-in because they're noticing an effect, then that's a real bonus clinically. And typically, almost all the tDCS studies have shown there's a fairly significant effect by the end of a 20-minute tDCS session that also lingers for a few hours and sometimes for a couple of days. So here's a little chart of current density. In this case, if we had 1 milliamp, you can see up here 1 milliamp, if that went into a 4x5 electrode, so this would be 4 centimeters by 5 centimeters. 5 centimeters is very close to 2 inches, and 4 centimeters would be a little less than 2 inches, about 1 5/8 inches or so. We'll work with centimeters in this case. So if we had 1 milliamp divided up by 20 square centimeters, we would have 50 microamps per square centimeter. That makes sense? Now we're using scientific notation. This is really no different than to say if we had a pizza and we divided a pizza into 10 slices, let's say, then we'd have 1/10 of the pizza would be per slice. But in scientific terms, that would be 100 milli pizzas. And if we cut a pizza into 20 pieces, then each piece would be roughly 50 milli pizzas. But because we're dealing with not 1 amp, but 1 milliamp, when you divide that into 20, you're going to get 50 microamps. Now, what if we wanted to double the current density? What could we do? Well, one obvious solution would be if we took 1 milliamp and we increased it to 2 milliamps, we would now have 100 microamps per square centimeter. But how else could we double the current density without changing the overall current? Well, this is how it's done. Get a scissors, cut your electrode in half. If we do that, now the current density will double. And there may be cases when you'll have to do that. You'll just need more kick. with your patient, and you can just cut your electrode down and really up your current density and have to ensure clinical effectiveness. So just to wrap it up a little bit on current density, if you had 1 milliamp and you had 25 square centimeters, which is 5 by 5, which is pretty much 2 by 2 inches, very close, you would end up with 40 microamps per square centimeter. If you had 2 milliamps, of course, that would double to 80. If you had 6 by 6, which some studies use, you're going to have 27 microamps per square centimeter. These studies typically don't yield much in the way of clinical effectiveness when they use a large electrode like 36 or 49 with only 1 milliamp. Our electrodes have been tuned to provide roughly 18 square centimeters on the treatment electrode, and sometimes we use 2 treatment electrodes. Sometimes we use the reference as a treatment electrode as well. But most of the time it's extracephalic. And anyway, this yields 55 microamps per square centimeter, which we know to be clinically effective. And there are times when I certainly run my own clients at 1.5 to 2 milliamps, and I push them up to as much as 110 microamps per square centimeter to get effectiveness. This is particularly noticeable at times of depression. And yes, 2 milliamps into an 18 square centimeter electrode can have pretty profound effects on relieving depression quite quickly within the same session. Some of the side effects that have been reported with tDCS, in fact, these are the major side effects reported with tDCS, and as you can see, there really isn't too much to be concerned about at all. So how does transcranial DC stimulation actually work? Well, there's several models on that. One of the models is that we're putting positive on the scalp, which is the anode, and we're running negative somewhere else in the body. So the voltage gradient is getting more and more negative as it goes through the scalp, through the layers of the brain, starting with the dendrites, working through the cell body, and then down the axons and out the tail end of the pyramidal neurons. And in the process of becoming increasingly negative, as it goes towards the tail of the neuron, it depolarizes the neuron to some degree. So instead of resting at minus 65 millivolts, inside potential with reference to the outside potential, it drops that down to about 55 millivolts. And that increases the odds of firing. The less polarized a neuron is, the less dendrites need to be stimulated to trigger an action potential through the neuron. On the other hand, if you put the cathode there and you brought that 65 millivolts up to maybe 75 millivolts and caused hyperpolarization, then you're going to shut down the neuron's ability to fire. And they'll take a lot more dendritic input to get an action potential from that neuron. Here's something else that has been discovered about the anode and cathode. The anode, and this is counterintuitive, so pay attention to this. The anode reduces GABAergic activity of the neuron, which excites the neuron. Typically, neurons are in a GABA glutamine or glutamate balance. And when there's more glutamate, neuron fires more readily. When there's more GABA, the neuron is calmed down. So the anode increases the excitation of the neuron, not by boosting glutamate, but by reducing GABA. The anode does the reverse. It settles down a neuron, not by increasing GABA, but by reducing glutamate. The orientation of the neurons may be a significant factor in determining the effects of tDCS. Pyramidal neurons, parallel to the current field, were activated by anodal tDCS and inhibited by cathodal tDCS in the study done by Beinman back in 1964 with his rat work. Now, that being said, as we know, the brain is full of gyri and sulci. And so if you're placing your electrodes over the gyri, over the sulci, you're going to be in parallel with the neurons. But down the sides, where they go into the sulcus, you're going to be hitting neurons cross-sectionally, or at perpendicular to the neurons. And it's hard to say necessarily what kind of effect that might have, if it has an effect at all. This is an interesting study right here. So this was the first study to demonstrate that tDCS increased dopamine in the brain. And they looked at dopamine transmission in the striatum after one tDCS session, 20 minutes at 2 milliamps. The electrode was 7x5, so 35 square centimeters. Current density was 57 microamps per square centimeter. And you can see on the picture on the left here, the type of montage that they use. They put the anode on F3 and the cathode on F4. This is a very common electrode placement for depression, although I typically don't subscribe to it very often. I will typically use the right cathode. As we see here, I'll use that cathode and I'll put it on the right shoulder rather than inhibit the right frontal lobe. And we'll talk about that a little bit later on. So anyway, this study showed here that dopamine indeed was increased in the brain with tDCS. Now this is interesting here. So these are some of the things that tDCS does, and it does a lot of things. tDCS affects voltage-gated calcium channels. It affects NMDA, glutamate, GABA, brain-derived neurotrophic factor, AMP-A, serotonin and dopamine, acetyl-CoA receptors, and voltage-gated neurons. So it has a tremendous effect on brain activity. It also affects firing rate and the pattern of firing within the neurons. And it also directly affects the network oscillations, as we see at the bottom of this graph. So it's important to remember. And on an EEG side of things, the cathode, the negative, typically increases delta and theta brainwave activity while reducing beta brainwave activity. The anode decreases delta and theta brainwave activity while increasing beta brainwave activity. So if you had a situation with a patient and you needed to increase delta theta and bring down beta, or you needed to decrease delta theta and bring up beta, you can do this within a 20-minute session using tDCS. There's no way you can achieve that kind of result with neurofeedback. Not possible. I'm not saying you don't use neurofeedback at some point, but to start off with, if you want to have a clinical effect and really get your patient on board, then I would recommend you start with tDCS and get the ball rolling that way. Now, all the studies that have been out there pretty much so far have shown that wherever you place the anode, you enhance neuronal activity. But this study put a twist in the works, and I'd love to see if this can be replicated because it really needs to be. I particularly enjoy studies that sort of mess with the order of things and show how maybe the status quo, maybe went sideways and didn't do the best job. So I like studies that challenge the status quo. And this study absolutely challenges it. What this study looked at here is they looked at all these electrode sites. Look at the top right here, mean eyes closed alpha on all these electrode sites based on the 1020 system. And they took an average mean eyes closed alpha frequency. Then they applied an anodal stimulation at F3, and they applied the cathode to F4. They also applied the cathode to the right wrist. They also applied the cathode to the left wrist. And what was interesting, so long as that anode was over F3, there was an increase in mean peak alpha eyes closed frequency, as we see here in those three graphs. Now, then they did their sham. The sham really had no change. And then when they applied the anode now to F4, and then they looked at the cathode on the right wrist and looked at the cathode on the left wrist, either which way, there was actually a slowing of mean eyes closed peak alpha. It's counter to the research that has been going on all this time, suggesting that the anode always enhances brain function and the cathode inhibits brain function. This study is really showing no, an anode on the left-hand side enhances brain function, but on the right-hand side, it might inhibit it. So we do need to see this study replicated or disproven. Here was one of the first studies on cerebral blood flow. Now with this study here, what they had done is they turned on anodal stimulation for 7 minutes. Then they turned it off for 7 minutes, turned it on for 7 minutes, off for 7, and on for 7. And you can see there is a net trending in the upward direction for cerebral blood flow. Okay, that was interesting. And then here they did cathodal stimulation, same idea. And we can see here too, the reference FP1, sorry, and the transmitter or the treatment is at C4. And you can see here that even the cathode does increase cerebral blood flow. But when they turn off stimulation, cerebral blood flow drops dramatically. When they turned it back on, less of an increase in cerebral blood flow and a larger drop again in cerebral blood flow when it was off. Turn it back on again and less cerebral blood flow again. When they turned it off, there's a very significant drop in cerebral blood flow. So even though cathodal stimulation does increase cerebral blood flow during the time of the stimulation, there is a net overall reduction in cerebral blood flow. This is a very interesting study, maybe a little better in some ways. Now, they happen to have these electrodes placed, as we saw in the other study looking at EEG, where the anode was on the over F3, the left dorsolateral prefrontal cortex, and the right is over F4. They're using 5x7 electrodes, 35 square centimeters, and they had 3 different current densities. They ran for a while at 0.5 milliamp, which is 14 microamps per square centimeter, so you really shouldn't see any effect from that. 2 milliamps, you would expect to see a strong effect because that's now 56 microamps per square centimeter, and 1 milliamp at 28, you'd see maybe a moderate effect. So that's what they had done, and then we'll take a look what they saw. Well, these are the effects that they saw in comparison to sham. So active is the red, sham is in the blue, and we can see at 0.5 there's some difference. At 1 milliamp, the difference is much stronger, and you can see where they turned it on. This is where the gray areas where they turned on the stimulation. And we can see that this hump is really showing an effect of tDCS. And at 2 milliamps, we also saw that hump going on as well. So we can see here that it does increase global glucose consumption as it increases metabolic activity in the brain. This study was another interesting study. There were 7 people in this study. And these lines, or these little lines, represent each person in the group. And what was interesting about this was they were looking at the effects of tDCS on chronic insomnia. So the right frontal lobe is typically more of a fear-based part of the brain, and it is more involved with retreat or avoidance behavior of negative stimuli, whereas the left frontal area, and again, right around F3 and above that nucleus accumbens, there's more approach behavior for things fun and exciting and wonderful. So the happy side is more on the left, and the negative brain functioning is, or negative effect of the brain is more on the right side at roughly F4. So this here is total sleep time. This is sleep latency, so how long it took to fall asleep. And this is sleep efficiency, which is overall time in bed divided by the time tossing and turning in bed. So non-sleep time, and that's sleep efficiency. And we can see here that the anodal group, and now this is over F8, whereas where they are placing the cathode and anode was over F8. And we can see the anodal group that had the anode over F8 actually got worse with total sleep time. They got worse a bit with sleep latency, and they got a little bit worse with sleep efficiency. The cathodal group, which is shutting down against more of the fear-based side of the brain, saw an improvement in total sleep time, dramatically reduced sleep latency, at least in one of their subjects, and overall improvement in sleep efficiency to some degree. So that's interesting because it kind of makes the point that, yeah, if we tune down that right frontal area of the brain, we can actually improve sleep that way. I've used it myself, and it has had an effect. It does work. Now, there were 3 generations of studies that came out on tDCS. The first ones were very, very, very basic. They just put an electrode over the site of interest for the treatment, and they typically put the the reference, which is typically the cathode, over the contralateral orbit, never checking to see if it was indeed causing inhibition of brain function underneath that cathode. And they did this for a few hundred studies over several years. Then a second generation of studies started coming along. And this came up with the discovery that you could use cathodal stimulation over the motor strip on the contralateral side or the homunculus side, and you could still improve it on the other side. And this was particularly noted in people with stroke, because with stroke, the other hemisphere of the brain tries to hijack functioning of the lesioned side of the brain. What they found was that in the process of the other hemisphere trying to hijack the lesioned hemisphere, is that it actually interfered with therapy. So by putting a cathode on the other side and keeping it at bay, it actually helped with the therapy. So that's what was discovered. And this was very important. So they went on with this, and that now meant that for stroke patients, they could put now the anode over the lesion side and a cathode over the contralateral side and the homunculus area, and they actually could improve therapy with this technique. Now, sort of the third generation came along, and this one might not have been as significant as the first two. What they found was that it didn't make a lot of sense to put the anode over the lesioned area because those neurons are taken out of commission. So it made more sense to put the anode over the perilesional areas. So the areas just around the lesioned area that could take over functioning of the lesioned section. Now, electrodes being 5 by 5 centimeters or 2 by 2 inches are more than likely hitting the perilesional areas anyway, because electrodes are fairly large. But it was certainly a little bit of a discovery that that's how it should be done. This is what they would call best practices, at least with stroke, and that would be putting the anode over the perilesional areas and the cathode over the homunculus site on the other hemisphere. However, there are some caveats to this, which we're going to look at later. Now, this is a study done looking at the medial prefrontal cortex. So that's the blue section right here, on impulse and anger control. Now, they were giving this person a type of buying and selling on a fake buy-sell website. And they were messing with him by ripping him off, in a sense, when he was trying to buy and do trading and stuff. And it was making this person very angry. And you can see just the degree of blue that is showing up in the prefrontal areas, frontal areas, and also the medial prefrontal cortex. And this is associated with activation of anger in the process and aggression. So they did transcranial DC stimulation in those areas, and you can see here now that activation of the prefrontal cortex caused a significant reduction in anger and aggression, despite having fair or unfair trading practices when he was playing this game. So that's pretty fascinating on its own, I found. You can use this certainly to treat aggression. This study here looked at using tDCS for athletics. And this is quite fascinating. So they find, of course, that when you're doing strenuous physical activity, there's a tiring effect of the muscle, and there's also a buildup of lactic acid, which can get very painful over time. So what they did here with this study is they ran anodes on both motor strips with ipsilateral cathodes. The cathodes are on the same side. In this case, they were running cathodes over the motor strip. They did assessments. They did a neuromuscular assessment. They did tDCS, another neuromuscular assessment, tDCS, a warm-up, and then tense till fail. And that's how they did this. So let's take a look. So we can see here when they tense till fail with the anode, they got an extra few minutes. Well, in the athletic circles, getting an extra few minutes of maximum muscle contraction over your opponent could certainly win you the game. You can see that with cathodal stimulation, there also was a mild improvement over the sham. Wasn't much, but it was a little bit. So just stimulation in general does seem to have an effect. When they looked again at blood lactate accumulation, we can see here that during anodal stimulation, there was a fair bit more blood lactate accumulated because this person, of course, is tensing significantly longer and is able to hold it despite the fact that there is lactate accumulating. And again, the cathode had a mild effect. So yes, this can be used in this manner for athletics. This is a wonderful case study that was given to me by a clinician, and this was one of his patients. This patient had to retire early from his employment due to severe anxiety while driving his car. He was also diagnosed with OCD and reported bad and dangerous thoughts. He had been seeing a talk therapist and psychiatrist for meds. Previous to the intervention, which was tDCS, he was taking clonazepam 1 to 2 times daily, usually in the morning. But at their most recent follow-up appointment, which was now post-12 tDCS sessions, the patient says that he's driving without fear now, and after doing the tDCS, he hasn't taken any clonazepam in the last week, and he's only taken 2 half doses the week before. He also reports a marked decrease in previous negative thoughts. So we can see here, there's his OCD right here, right down the cingulate, in 3 bands, theta, alpha, and beta bands. And this is also his relative power here, but the absolute power really shows the OCD. Post-tDCS, this is what we've got. The cingulate is settled down, and the OCD is gone. So that is the effectiveness of transcranial DC stimulation and how well anodal stimulation in this case can work for treating OCD. So here's a study here, and we can see here where they looked at EEGs, and they're looking at a control group, a normal group, compared to an OCD group. And what we see here, when you're looking at the delta band, we can see the differences with OCD compared to the normal group. And again, look at the cingulate areas here. There's temporal lobe issues as well that are hot. And that's in the delta band, so high delta, high theta, compared to the controls as well. And we can see that right here in this band. After treatment with tDCS, we can see that both groups look remarkably the same in both the delta band here and the theta band over here. So it shows that indeed tDCS is quite effective at treating OCD. I must say I've used it for many years for OCD, and it is very effective indeed. So let's talk about stroke now. So with stroke, this is an example here of someone perhaps who had a motor stroke. Now the motor side this is the lateral fissure right in here. And this is the motor side. This is the homunculus, and this is the motor side here. And the sensory side is in the parietal lobe, basically right behind it. And it's important to know that when you're placing your electrode. Are you having sensory issues, or are you having motor issues? The fissure runs on the right-hand side as well, and you can see it running through here. So we've got motor on the one side and sensory on the other side. And this is what the homunculus looks like. And this is the motor area. The sensory is somewhat different, but this is the motor side here and what that looks like. And in this case, if someone had a stroke and it was lesioning something, let's say their hand or their face maybe, you could kind of target where you put that anode and treat that area more specifically. This slide depicts some of the amazing things you can do with transcranial DC stimulation when you have adequate current density, or you're willing to take a chance on stimulating parts of the brain that you might think could influence functionality in your patients. This here is a patient with Parkinson's disease, and he has an inability to lift clothing over his own head. The clinician gave him 1 session of tDCS. It was 20 minutes at 2 milliamps. Now the electrode used is an 18 square centimeter electrode that we provide with our equipment. And so it was getting roughly 110 microamps per square centimeter. The anode was placed on the bilateral cerebellum, so below O1 and O2, and using the long skinny electrode. And the cathode was on the right upper trapezius. So let's take a look at the video here, and you can see how this person functioned pre and post 1 session of tDCS.
Up like you're going to put it around your neck like a handkerchief or something like that. Get stuck kind of right there?
Yeah.
Okay, and then bring it back over. Okay.
Okay, now this is post 20 minutes of tDCS. And as I mentioned before, the effect is quite rapid with transcranial DC stimulation.
Put this corner of the handkerchief here, that one there. Let's put on your vestments. Look at that. You're a different guy.
I haven't been able to do that in a long time.
Well,
Has come from the floor, but this is
much big difference. Do me a favor, we didn't check this before. You got a button right here. See if you can button that. How's that usually for you?
Takes longer than that most of the time.
Okay.
There you go. You can see on the table there, that was an Oasis Pro. And they were using the tDCS function from the Oasis Pro. Now, one of the nice things too about improved functionality that we typically find is that once a person has improved functionality, the brain now has, in a sense, risen to a higher level of functioning and has a tendency to hold. So it doesn't mean you still wouldn't do further tDCS applications and also ongoing therapy, but it sure does help with the process, and generally it sticks fairly well. They're getting to be a large volume of studies on aphasic patients. This is back in 2012, and we could see back in 2012 already, there were studies looking at many areas of the brain involving aphasia on the left and on the right-hand sides, mostly on the left. And again, using the cathode on the contralateral side is going to actually improve therapy. Now, this is looking at the upper extremity Fugl-Meyer, or UEFM test, and it has to do with fine motor control. And then we're looking at the Wolf motor function test down here, which has to do with timing or latency to do things. So we can see here, when you come to look at sham versus tDCS, fine motor control had improved significantly with tDCS compared to sham. When you look at the time it took to complete the task, we can see that there are significant improvements with tDCS compared to sham in terms of the time it took to accomplish the tasks. There were 20 participants in this study. There were 5 months post-stroke. tDCS was 1.5 milliamps at 30 minutes, 5 consecutive sessions. And we can see here that the electrode size was 16 square centimeters, so a 4x4 electrode. And at 1.5 milliamps, that would be a very high current density. And in this case, you probably needed it. This goes to show that when you do tDCS, it actually really helps to engage in the activity relating to the part of the brain that you are stimulating. And here they're looking at trained nouns versus untrained nouns for anodal stimulation and for sham. And what we can see is immediate post-testing, anodal stimulation versus sham, and 3 weeks post-testing. And what you can see here is when you do trained nouns, tDCS is significantly more effective. It really helps cement in those associative areas of the brain during therapy. If you're doing untrained nouns, in this study anyway, there was not much difference between treatment and sham. called anodal stimulation and sham. So yes, engage in the activity that you're trying to treat in. If I'm working with depression, for instance, we will try cracking jokes and being funny, and you can even play cartoons or other or comedy on the computer and help a person learn to laugh while they're being stimulated. Now, this is a very pivotal study. Some of the studies were showing, of course, that you put the anode on the perilesional area over the stroked side of the patient, and the cathode on the homunculus side in the other hemisphere. But other studies showed it didn't work. So at some point, Schlag, or 2008, Schlag and his group did diffuse tensor imaging, and what they had found was was if the descending tracts were actually destroyed from the stroke, as we see here, then it didn't make any sense to try to treat or stimulate the perilesional areas because there was nothing you could work with. In this case, it was best to put the anode on the contralateral side and encourage that side of the brain to hijack the circuits on the affected side. In this case, this is the left hemisphere, so affect the stroked side and hopefully hijack those circuits and get them into functioning. However, if the lesioned side was still very intact with regards to all the ascending fibers and descending fibers, then it made sense to apply the anode to the perilesional areas around this and the cathode to the other hemisphere to prevent that from hijacking the circuits that you could rehabilitate with the anode on the affected side. So, in conclusion, if the stroke is small and perilesional areas are intact, then excite the perilesional areas while inhibiting homotopic or homologous areas. If the stroke is large and perilesional areas do not exist, then stimulate the homotopic areas directly with an anode. Okay, now we're going to look at some basic electrode placements and things we've done over the years that have been written upon in the research, and of course there's even more coming out all the time. So this is the placement I generally use with depression, and a few studies have corroborated my belief that we should be careful not to put the cathode on the right frontal lobe because we can cause problems there. So I use the anode typically over F3, and I will use the right shoulder for the cathode. Now, if it's acute depression, you can perhaps get away with this because with acute depression, sometimes the right dorsolateral prefrontal cortex becomes hyperactivated and you need to settle it down, whereas the left needs to be brought up. In this other example that we had just looked at back here, this would be chronic depression where people have had it perhaps for 10 or 20 years. And when we do a QEEG, what we find is that both sides are not functioning that well. Just the left frontal areas are functioning worse than the right frontal areas. So we don't see a point in knocking down the right frontal areas even more. And that's why we use the right shoulder instead. Okay, here's a study looking at this for attention. And we have a long skinny electrode that you can apply across both sides, both FP1, FP2, and put your cathode on the neck. Sometimes you may have to use a little cushion behind the neck and have them lean against the chair or lay back against the chair just to keep some pressure on that cathode, and that's a pretty good placement. This also works remarkably well for pain, which we will talk about in a little bit. One of the beautiful things about transcranial DC stim is the ability to assess and evaluate and measure almost any mental function imaginable. In this case, the function was insightfulness. And in this study, the participants were given very intricate, clever puzzles and mind games, which they needed to solve. And when the anode was placed on T4 and the cathode was placed on T3, their ability to solve these puzzles and such were enhanced significantly over the reversal, where cathode was on T4 and the anode was on T3. And this is probably due to the fact that the left hemisphere is largely involved in sequential type processing, whereas the right hemisphere is more involved in global holistic type processing. And so by enhancing that, people were able to make parallel connections with the concepts they were working with, and therefore able to resolve them more speedily. This is on socialization, and this has been found, the right temporal parietal areas have a lot to do with facial recognition, interpretation of emotional facial expression. And so far, about 3,000 facial expressions have been cataloged to date, and they're fleeting. So you need to have sharp temporal lobes if you're going to want to engage socially. And the parietal lobes are also involved in that processing of that information. So by putting electrodes in this area, in the right temporal parietal area, is one way of boosting socialization. Now, language is important for socialization, so I don't recommend putting a cathode over the left parietal area. I would recommend the left shoulder. This is looking at math that was not basic algebra, but math that was far more abstract and sort of perceptual. And when they had the anode over the right parietal lobe, math improved a fair bit compared to the cathode over the right parietal lobe and anode on the left. Unfortunately, in the study, they did not check to see if they were actually causing language or speech impairments when they had the cathode over the left side, which was pretty close to Wernicke's area. And I wish they had. Again, this is one of the failings of a lot of the research done in tDCS. As amazing as the technology is, I think they should have upped their game a little bit better and looked at the effects underneath the cathode. This is a study on vision, and they found that when it came to discrimination of very, very, very fine differences in hundreds of different shades and color blends and so on. And they found that when they did the anode over O1, O2, and in this case, they used the cathode at the vertex, people could do much improved shade discrimination. Well, from a military perspective, if there is camouflage and such under a jungle canopy, let's say, or a forest, it might help a pilot to be able to discriminate those subtle shade differences between the camouflage and the forest and spot the enemy. But another application, maybe a friend in your application, could be that for interior design. So if someone is in the business of being an interior designer, and if they were to run the anode back here over the occipital cortex, it might actually improve their workmanship and their quality of work with their clients by being able to discriminate fine shades of color. Now, this is a study that was done on auditory pitch. And yes, so if you put the anode roughly on the T3 area where basic auditory processing is occurring, you can actually improve their sensitivity to pitch, and they could sing more on key in the choir. I had a personal experience with this because I myself am a amateur singer-songwriter. And after singing and playing guitar for years, one day it was pointed out that my singing wasn't really that on key, which I wasn't pleased to hear, and I didn't believe it. But anyway, I thought, well, I trusted this person's opinion on this. So I ran cathodal stimulation in my T3 area, 5 consecutive treatments over a week from Monday to Friday. And yeah, and by that end of that Friday, I was definitely aware I was not singing on key anymore. I was a little bit off, I was a little pitchy, and I often didn't tune my instruments that well. And now it annoyed me, and so it upped my game. And that's one of the cool things about transcranial DC stim, or any therapy really that improves cognition, is once the perception is improved, it doesn't go back, because now you're functioning on a higher level. And you will probably never lose that functioning, because now you've set the standard and now the brain gets it. And yeah, so you've raised the bar basically, and then the brain will continue to stay at that functioning level. A lot of studies that were done to treat pain looked at putting an anode over the motor strip with a contralateral cathode on one hemisphere or the other, and they could reduce pain in the opposite side of the body. But some people they took exception to this. They just didn't really believe that it could work, especially if you're exciting the sensory motor area. How would you reduce perception to pain? This is when a doctoral student named Mendonca figured, well, maybe there's more going on with this. Perhaps those contralateral orbit electrode placements are activating pain gates in the cingulate gyrus, and that is actually having an effect on reducing the perception of pain. So she went about to do a study where she basically put anodes over FP1, FP2 with a cathode on the neck. And then she also put cathodes over FP1, FP2 with an anode on the neck. She found that in either situation, pain perception was reduced, but it was reduced mostly with anodes over the prefrontal areas. which is a good thing too, because I mean, that affects cognition, attention, impulse control. So we would want to see anodes over the prefrontal areas. Plus, when a person has better cognition and better emotional control, perception of pain is generally improved. Or in terms of pain is less upsetting to them emotionally. And so, yes, so this is a good technique, putting anodes over FP1, FP2, just as we saw earlier with that attention montage, which is exactly the same placement for improving attention. So yes, you can improve attention, cognition, and reduce perception of pain with FP1, FP2 electrode placements. So this is an example here now of treating, in this case, Broca's aphasia and stroke. Now it looks to me like somehow in translating of some of these slides when we reformatted them, I can see the anode and cathode are not quite in the right place. So they would be down, they would be dropped down a little bit more. A would be more down here a little bit at F3, cathode would be at F4. And we talked about this earlier, why this works. So we're not going to go over that again. And here's an example of Wernicke's aphasia. And again, the anode would be a little more down here and the cathode would be pretty much where it is. And we would use that for Wernicke's aphasia in stroke, assuming the paralesional areas are fairly intact. Okay, and if you want to learn more about stroke, this is an excellent study that has a very nice summary, good lit review of many of the studies that have looked at aphasia in stroke. Highly recommend that you look at this study if indeed you work with stroke patients struggling with aphasia. I'd like to thank all of you for attending my lecture. I hope you found it exciting and elucidating and enlightening. And hope to see you again in the future. And meanwhile, I wish you all to stay well and healthy. Thank you very much again. Bye-bye.